Welcome to the deep dive. Our mission today, well, it's to take these specific revision notes we have on anorexia nervosa and really unpack them for you.
Exactly.
We're aiming to pull out the key points, the high-yield stuff, to make this information stick, especially if you're in the middle of a revision.
That's the plan. We're using these notes as our guide. Anorexia nervosa, it's a really serious condition, quite complex, often misunderstood, so we'll break it down section by section from the notes.
Yeah, we'll go from the definition right through to complications, sticking just to what's in this material. Let's try and make it feel a bit less, daunting.
Sounds good.
Okay, let's start right at the beginning, the definition. How do these notes actually define anorexia nervosa?
Okay, so the core definition here is an eating disorder involving a really distorted body image, this intense fear of gaining weight, and crucially, severe food restriction.
And that restriction leads to significant weight loss.
Exactly, significant weight loss.
What about specifics, like the criteria used for diagnosis?
The notes point to the ICD-11 criteria. So key things are low body weight for age and height. For adults, that means a BMI under 18.5.
Okay.
And for children or adolescents, it's being below the 5th percentile. They also mention rapid weight loss, like more than 20% in 6 months. That can also be an indicator.
Right.
And then there are those persistent behaviors to stop weight gain and that central overriding fear of getting heavier.
So it sounds like the behavior and the fear are just as important as the actual weight number. The notes mention stuff like self-imposed starvation, extreme weight control efforts, and the risk of severe malnutrition. And they state a 10% mortality risk, which is, well, it's high.
That 10% figure is, it's sobering. Really underscores the seriousness. And the notes are clear. It's a clinical diagnosis made by a professional based on the whole picture.
Not just one single thing.
Not just one thing. And it's got multifactorial causes, lots of things interacting.
Okay, that leads us nicely into the causes, the etiology section. What do the notes say contributes to it?
Well, they really stress the complexity. It's a mix, genetic factors, biological ones, psychological aspects, and environmental influences, too.
A bit of everything?
Pretty much. Multifactorial is the term they use. Yep. It's not totally clear, the exact balance between maybe an underlying neurobiological vulnerability and, say, cultural pressures, but it's definitely an interaction between all those elements.
So with that complex mix, who's more at risk? What risk factors are listed in these notes?
Right, the notes give a good list. There's genetic predisposition, so maybe a family history of eating disorders, or, interestingly, other mental health conditions.
Oh.
Personality traits come into it too, things like perfectionism, maybe being very detail-focused, and low self-esteem.
And that societal pressure for thinness you mentioned.
Absolutely, that's listed explicitly. Also, female gender, though, it definitely affects males too, that's important. Age is a factor, adolescence, early adulthood, with a peak onset around 15 to 19 years old. Participating in sports or activities where thinness is emphasized, having a history of dieting or trying to lose weight before, and certain personality traits, maybe leaning towards obsessive-compulsive tendencies.
Okay, quite a few factors there. So moving from the why and who to the how, the pathophysiology, how do these factors actually sort of play out in the body?
Well, the notes describe these complex interactions again. Psychological, social, neurobiological factors all playing a part. They mention changes in brain chemistry specifically.
Like neurotransmitters.
Exactly. Imbalances in things like serotonin and dopamine, which, regulate mood, reward, appetite. There seems to be a dysregulation in how appetite itself is controlled, plus changes in neuroendocrine function, the brain hormone communication pathways.
So the restriction isn't just willpower. It actually starts to change the body's signals.
Precisely. And the ongoing energy restriction itself, the starvation state, drives metabolic and hormonal changes. Your body adapts, hormones shift. And this ties into those cognitive distortions, those persistent, difficult thoughts about weight, shape, food, that kind of keep the cycle going.
Okay. Now, sometimes conditions can look similar. What about differential diagnosis? What else might present like anorexia nervosa?
That's a really crucial clinical step. The notes list differentiating it from other eating disorders first, like bulimia nervosa, which has binging and purging cycles, or binge eating disorder.
Different patterns.
Different patterns, yeah. But also, critically, ruling out medical conditions that cause weight loss. Things like malignancies, GI disorders affecting absorption, chronic infections.
So a proper medical workup is essential.
Absolutely. And other psychiatric conditions, too, like major depression, can sometimes cause weight loss. Body dysmorphic disorder is another one mentioned, where the focus is more on perceived flaws rather than weight itself. but ruling out underlying physical illness causing the weight loss is key.
Okay, shifting gears a bit to epidemiology. Who gets it? How often? What do the notes say?
They state it mainly affects young females, but again, males too. The estimated prevalence in the general population is sort of 0.5% to 1%.
Right.
Lifetime prevalence, so the chance of having it at some point, is higher in women, maybe 2 to 4%. And as we said with risk factors, the incidence, the new cases, peaks in that 15 to 19 age group.
And there were UK-specific numbers.
Yeah, the notes give UK figures of around 1.25% for females and about 0.29% for males. So yeah, common in adolescence, early adulthood, and tends to be noted more in higher socioeconomic groups and Western countries, although that might be partly about reporting or access to care.
Right. Let's get into the clinical features. What do you actually see? What are the key signs and symptoms listed?
Okay, core features are significant weight loss, that distorted body image we talked about, the intense fear of weight gain, obviously restricted food intake, and often excessive exercise. There's usually a big preoccupation with food, calories, body shape, lots of body dissatisfaction. And in females, menstrual irregularities or periods stopping altogether, amenorrhea.
And how is the diagnosis made in practice? The notes mentioned it's not always straightforward.
Yeah, they say diagnosis is clinical based on history, the features, maybe concerns from others. And they specifically say no single measure, like just looking at BMI, is enough.
Right.
It can be tricky to spot, especially in primary care, maybe because people hide symptoms. And really importantly, someone can look outwardly okay, or their assessment might seem normal, even when they're medically unstable. That's a real pitfall.
Wow. Okay, so you can't just rely on screening tools.
Definitely not. You need a proper assessment.
What about specific physical things you might see or find?
The notes list things like refusal to maintain normal weight, active dieting or restriction, rapid weight loss, that dread of weight gain, the distorted body image, often denial about how serious it is. Social withdrawal can happen, and specific behaviors like purging or excessive exercise. Physically, amenorrhea in females, GI issues like bloating, constipation, fatigue, dizziness. Key examination points are height, weight, BMI calculation, core temperature, checking the heart and circulation, and muscle power, like asking someone to do a squat.
And what might that examination actually reveal? Any specific findings?
Yeah, findings can include bradycardia, a slow heart rate, hypotension, low blood pressure, sometimes peripheral edema, swelling in the feet or ankles, a generally gaunt appearance, lanugo hair, that fine downy hair can appear, scanty pubic hair, and acrocyanosis, bluish hands and feet from poor circulation.
Really paints a picture of the body under stress. The notes also list physiological abnormalities, things you find in tests. What are the key ones?
This is where you see the internal impact of malnutrition. A really important one is hypokalemia, low potassium, very dangerous for the heart.
Right.
Hormones are often affected, low reproductive hormones, FSH, LH, estrogens, testosterone, but stress hormones like cortisol and growth hormone can be high. Other things. Impaired glucose tolerance, so blood sugar issues. High cholesterol, paradoxically common. Hyperkeratinemia, which can give skin a yellowish tint. And low T3 thyroid hormone, showing a slowed metabolism.
That's a huge range of dysfunction. So beyond a clinical picture, the investigations are needed. You said diagnosis is clinical, so tests are for complications.
Exactly that. Investigations are primarily to assess and monitor the physical complications. The notes list things like ESR and thyroid function tests, TFTs initially, partly to help rule out other causes of weight loss.
Makes sense.
Then urea and electrolytes, UNEs, are critical, especially checking potassium, particularly if there's vomiting or laxative use.
And for people who are very unwell.
For those with a very low BMI, like under 15, or other high-risk signs, more frequent bloods are needed. Full blood count, FBC, ESR, UNEs, creatinine for kidneys, glucose, liver function tests, LFTs, and TFTs. A DXA scan is important for bone density. Malnutrition really impacts bones. The timing depends on age and how long they've been underweight. And an ECG is vital in severe cases to check the heart rhythm for things like bradycardia or a prolonged QT interval.
The notes mention guidelines for assessing risk, too. Marzipan.
Yes, marzipan, it stands for Management of Really Sick Patients with Anorexia Nervosa. These guidelines give clear markers for identifying severe risk. For adults, this includes specific low BMIs, below 13 is high risk, 13-15 is medium. Rapid weight loss, very low pulse, low BP, signs like not being able to squat, Low temperature, abnormal bloods, ECG changes, they all contribute to assessing risk level.
Right.
And similar criteria adjusted for age exist for under 18s. These help decide if someone needs urgent medical admission.
That really highlights the medical dangers. Okay, let's talk management. How is it treated according to these notes?
The standard UK approach described is multidisciplinary, so a team effort involving nutritional rehab, helping regain weight safely, psychological therapy, and medical monitoring.
Tailored to the individual.
Absolutely. Individualized. Can be outpatient, day patient, or inpatient. The key first step is immediate referral to a specialist eating disorder service for the right age group.
And the main goal of treatment?
The notes stress this. The primary goal is reaching and maintaining a healthy weight, or BMI. That physical restoration is often crucial before the psychological therapies can really work effectively.
And different therapies are recommended for different ages.
Yes. For children and young people, the notes highlight FTAN, which is family therapy focused on anorexia nervosa. Individual CBT is also an option. For adults, it's things like individual CBT specifically for eating disorders, MSRA, or SSCM, which is Specialist Supportive Clinical Management. Different structured talking therapies.
What about the medical management during treatment?
Regular monitoring is key, especially electrolytes and ECGs during refeeding. Supplementation if needed, dental checks if vomiting is an issue, specialist advice for bone density problems. Age-appropriate multivitamins and minerals are usually recommended. Dietary advice is obviously central, but the notes explicitly say medication isn't a primary treatment on its own, and evidence for physical therapy is limited. Collaboration is needed if other conditions are present.
And when would someone need urgent hospital admission?
The notes list clear criteria. Severe physical complications like electrolyte chaos, severe malnutrition, organ failure signs, very low vital signs, heart rate, blood pressure, dangerously low BMI, rapid weight loss continuing, or significant suicide risk. Specialized units handle these really severe cases.
Okay, looking long-term now, prognosis. What's the outlook like?
It's variable. The notes give some figures. Maybe around 46% achieve full recovery long-term, about 34% have partial improvement, but about 20% develop a chronic, long-lasting illness.
So not everyone fully recovers.
Sadly, no. The outlook seems better for adolescents if treated early, maybe up to 60% recover. But a longer time being ill before treatment makes full recovery less likely.
Are there factors that suggest a poorer outcome?
Yes, meeting hospitalization and having the illness start in adulthood are linked to poorer prognosis. Relapse is common, especially in the first year after treatment, and there's a high risk of other psychiatric issues like depression or anxiety.
And that mortality rate again.
Yeah, the notes reiterate it's over 5 times higher than the general population. Main causes being those cardiac complications, severe infections due to weakened immunity, and suicide.
Such a serious point. Finally, then, the complications. What specific health problems arise from the malnutrition?
It's pretty extensive, affecting nearly every body system. Psychologically, anxiety, low mood, suicidal thoughts. Socially, relationship issues, isolation. Physically, the notes list them by system. Cardiovascular arrhythmias, low BP, sudden death risk, musculoskeletal muscle loss, bone loss, fractures, endocrine thyroid issues, problems with sexual development, gastrointestinal slow digestion, constipation, bleeding risk, hematological low white cells, anemia, metabolic dehydration, electrolyte chaos.
It just goes on.
It does. Neurological concentration problems, seizures in severe cases, renal kidney stones, kidney disease risk, dental enamel erosion from vomiting, and obstetric gynecological infertility risks in pregnancy.
Wow. It truly impacts the entire body. And mortality often stemming from these physical consequences or suicide, as mentioned.
Exactly. The medical results of starvation, heart problems, infections, plus suicide risk.
When you lay it all out, like the complex causes, the widespread physical impact, the variable prognosis, the risk of it becoming chronic, it really makes you think.
It does. It leads to a deeper question, doesn't it?
Yeah. Perhaps a thought for you, the listener, to take away from this deep dive. Given everything we've just unpacked from these notes, the multifactorial causes, the profound physical effects, the challenges around relapse and chronicity, what does this tell us about what recovery truly entails and the kind of long-term, comprehensive support individuals facing anorexia nervosa actually need?
Understanding that whole interconnected picture, the biology, psychology, environment, physical health, it feels absolutely vital for providing effective support.
Absolutely. Well, that brings us to the end of this deep dive into the Anorexia Nervosa revision notes. It was definitely dense material, but we hope breaking it down like this, focusing on the key points from the notes, has made it feel a bit more manageable and high yield for you.
Hopefully helpful for revision or just for understanding.
Feel free to revisit the different sections as you need to.
Yeah, seeing how the definition links to features, links to complications, that helps it make sense.
And hey, if you are prepping for something like the MSRA and you found this way of going through notes helpful, you might want to check out pastthemmsra.com. They have more resources tailored for that.
And for other free resources across different medical topics, you could also have a look at freemsra.com.
Great. Well, thanks for joining us for this deep dive.